Part of the conversation by heading onto our social media platforms at Science TV Kenya, at the Island Herbert, hashtags hashtag Science Breakfast, hashtag the Island Herbert. And at this juncture, allow me to welcome you so that you could greet the viewers, and also tell us who you are.
Good morning, viewers. I'm Joseph Otieno from NHIF headquarters. I work in the benefits and actuarial services department.
Actuarial. Is this the actuarial science that we hear in universities?
Exactly.
Just to educate our viewers, how is actuarial science connected to NHIF?
Okay, basically, actuarial science is involved with calculations. NHIF is all about projections,
Yeah.
pooling of funds, and then now you have to look at how you divide the funds into where what do you pay for.
Yeah.
You have to do simulations to ensure it is sustainable, so that you can also predict how much you're going to use within that year, and also plan for the future. So all strategic plans involving NHIF
Yes.
are always actuarial based.
Interesting.
Yes. Yeah.
For some reason, I thought actuarial science had to do something with aeroplanes and all of that.
No.
All right, karibu sana Science TV. And to start off the conversation, I don't think that we have talked about this overly enough. But if you do not mind, what does a member of NHIF, what do they stand to benefit when they become a member?
Okay, so basically we are in a new contracting cycle. So
Yes.
with this contract, the new contracts we have right now started in July last year. So what we did, we have a broad category of 7 new benefits,
Yes.
7 benefits.
Yeah.
And this is outpatient, inpatient, the surgical benefit package.
Yeah.
Then we have maternity, and then we also have now the oncology service,
Yes.
which is cancer related. Then we have radiology.
Okay.
Yes.
So those are the benefits that a person who is registered with the NHIF would stand to get.
Yes.
All right. And how does one get to access the NHIF benefits?
Okay, so first you need to register as a member.
Yes.
And you can do this through our branches. We have branches throughout the country.
Yes.
And then you can also visit any Huduma center. And you can also be able to register when you visit a Huduma center.
Yes.
We also have an online portal that allows registration through our website. That
Yeah.
is www.nhif.or.ke.
Okay. Yeah.
So you'll also be able to make a registration there and then upload your details. You'll be required to have your ID
Yes.
as the member or passport. And then if you have a spouse, you also need to have an ID of the spouse.
Yeah.
And then for children, you require birth certificates.
Yes.
So when you're registering online, you'll just be able to upload those documents, and then the registration will follow through.
All right.
Yeah.
And where do I have gone through the process of registering, and I am a bona fide member, and I am also remunerating my deposits. Where do I now get to access the services that you mentioned?
Okay, no, first now normally follow through with the biometric registration.
Yes.
Because we have gone fully e-claim. And so once you registered online, when your biometrics have been taken, the same for your beneficiaries,
Yeah.
we have 2 sets of facilities. Normally we have facilities we call comprehensive facilities,
Yes.
and those we call non-comprehensive facilities. So access is available to both.
Yes.
Because majority of hospitals are under NHIF. We have almost 8,000 facilities on board. But once you choose where to access, because the benefits are restricted based on where you choose to access services. For example, if you visit a comprehensive facility, the majority of the services will be free.
Yes.
Not free per se, but you won't be required to pay anything out of pocket, apart from a few cases like cancer,
Yeah.
and maybe now some surgical cases that might go over and beyond.
Yeah.
Yeah.
And you're talking about you mentioned about outpatient services, and why do I need to choose an outpatient facility? Why is that particularly important?
Now what happens is for outpatient, we do a model called capitation. The different payment models that we can always adapt.
Yes.
So for capitation, you need to choose a hospital in advance for you to be able to because you pay before you visit.
Yes.
Yeah, so once you choose a facility, then you'll be able to access services in that particular facility without incurring any other additional cost. And the model allows you, each and every individual in a family, to choose a different facility. So for example, if you as the member is in a different town, maybe in Nairobi, there's a child in school, maybe in Mombasa, and then maybe your spouse is in a different town, each of you can choose a different facility independently. Under the same card. Yeah.
All right. Very interesting there. And there is something that you had mentioned that probably you might extrapolate on a little bit. Comprehensive, non-comprehensive. Would you explain a little bit? Why would one facility be comprehensive, and why would another one be non-comprehensive, and what are the characteristics or the traits of these two different types of facilities?
Okay, so now what happens is, towards achievement of UHC, you have to enhance access. So you give people a choice on where they access, and also you give facilities a choice on what they want to offer. So a facility that chooses a comprehensive contract is willing to undergo some risk so that they cushion the members against out-of-pocket payments. So what it means is, if you visit a facility that is comprehensive, and most of them, like all government facilities, are under the comprehensive contract, and then we have majority of the mission hospitals, and then a few private hospitals are also on under the comprehensive. So when you visit this facility, if you choose it as an outpatient center, you'll be able to get outpatient services without any co-payment. And then if you choose it as, if now you go there for admission, the same applies. You won't be able to pay anything extra. If you go there for a surgical procedure, it will simply be pre-authorized, and then the surgical procedure will be done. Same to other radiology and the rest. But now for the non-comprehensive, these are facilities we have allowed to co-charge. So if a patient visits a facility that is non-comprehensive, you'll only pay a portion of the bill. So the rest of the bill will be either be paid by the private insurance that this patient has, or out of pocket. So that's basically the difference.
That's the difference. And you brought in a very key topic. You actually went ahead of me, because I wanted to ask, how do I pay to access the benefits? But after telling us how can one pay to access the benefits, I want us to make the conversation a little bit longer. There have been conversations or questions. If I have NHIF, which is mandatory if somebody is employed, and also the government is pushing for people to at least have that cover, and I also have a private healthcare benefit that I am setting up for myself, what would it take to marry the two, so that if I necessarily do not need to have another health sort of insurance with a private firm, but I would rather do it with the National Health Insurance Fund? Weigh in on those two questions.
Okay, now what happens is, the government is very serious about UHC, and if you go through the Kenya Kwanza manifesto, you'll be able to see the plans they have for healthcare. And it's all borders on offering all the level of services. So you have primary healthcare, there's the treatment, and then the tertiary, which is palliative care, and the rest. So what it means is, even the conversation going on now is how to restructure and ensure all these other benefits are inclusive, so that patients don't really need to have a private insurance, unless now you want to choose exactly where to go to. So currently, if you have a private insurance, you can choose to use either. But under the new regulations that we have, which are still under some kind of review going on, your private insurance will take precedence first. So if you go to a private hospital, for example, then you lose your private insurance. But in case you need to use NHIF, when you exhaust your private insurance, then NHIF comes in.
Now will kick in.
Yes.
And now that is sort of to lure people to come more into the NHIF basket as compared to being on a private insurance.
Yes, basically, because if you look at the rates that you pay for private insurance and you compare the rates that NHIF have, then you'll realize it's far much cheaper as compared to private insurance. And then you also realize the government is also cautioning the
Break. We're still watching Science Breakfast with me, Alan Herbert, and sign language interpreter right now is Gideon Miner. We are in studio with Mr. Otieno from the NHIF. He is one of the people who are in charge of making sure that the mathematics for benefits is done to the latter, and it is done properly. And Mr. Otieno, before we went for the break, I had posed a question in terms of what reforms have been put in place to ensure that there is a seamless service and delivery. We've had we've come across clients who reach us on our platforms, and they're like, "Oh, I applied, I have been paying, but unfortunately, I'm not able to receive services." What reforms have been put in place to ensure there is seamless service delivery?
Okay, so the first reforms is a continuous process.
Yes.
It never stops. So the main reforms that took place was we have a new structure. We changed our structure in terms of how we operate. That I am in right now, benefits design and actuarial services.
Yes.
So we can be able to do things more scientifically and rely on data to make decisions.
Yeah.
And then I also mentioned DPM. So right now all our systems are online, they're web-based. So when you go to access services, you no longer require all this paperwork. You just need to have your fingerprint,
Yes.
and then you'll be able to access services. So this also has helped a lot.
Yeah.
Yeah, because we realize you're not being able to get clear data in terms of what Kenyans need. So that will also making decisions. So the other reforms I'll talk about is in terms of the benefit package. I mentioned we have a contract that we rolled out in July last year. It was the first contract that were well, there was a good stakeholder engagement. And we also had a robust input in terms of costing for various services so that we're able to know how much various services cost. We also went through even the surgical package. We increased the benefit scope almost twice from around 300 to 600 procedures. We added more radiological package the benefits. We included now, we support echocardiogram. We also support for EEGs. We have Doppler ultrasounds and also all the other benefits. Yeah, so there's a lot that has happened in terms of reforms. So in terms of access, there's those differences. We now have an e-claim system. The benefits design has been improved. The benefits package has it been improved to now include these other benefits. Yeah.
And for a person who still is trying to understand the correlation between the NHIF and UHC, what would you tell them just to clear the air? Are these two different elephants in the room, or are they? How is the NHIF working to marry the UHC within its ecosystem? Just as you rightly put that you're working towards also to connect your system to the Ministry of Health. Is UHC detached entirely from the NHIF?
Okay, now UHC is a government project through the Ministry of Health.
Yes.
But now the government empowered NHIF to now roll out UHC. So as for now, from my point of view, NHIF and UHC is the same thing. Because the only difference is now we have those indigents who are being paid for by government. But remember, for NHIF, the benefit package is the same. So the benefits you get, whether you're being paid for by government, you're paying for yourself, or you're employed, are the same. So we have that aspect of standardization of benefits. And that is how we move towards UHC. And then you've also been given a choice to choose where you want to access services. So if you don't want to pay, then you know where to go to, and it's well defined. And if you have a private insurance or you're willing to pay for services, then you also know where you can access these particular services. So by the end of the day, that moves towards achieving UHC.
because remember we also have to give the hospitals a choice in terms of what type of contract they have to offer, and then we also have all these other Kenyans that also depend on these other facilities. Yeah.
Interesting. And this probably might be a vote of confidence in what NHIF is doing. The question would be more of a vote of confidence. If you do not mind, what really goes into structuring a package that I need radiology services. This is how much you are able to spend under NHIF, or I am under chemo. This is how much you're supposed. Could you just paint a picture for a viewer to understand what really goes into coming up with those particular packages and the amounts that are attached to these packages?
Okay, now the two things. The first aspect is the costing.
Yes.
So before
with baselines. So we love to visit different cost centers and come up with cost for every line item.
Yeah.
Then by the end of the day, come up with a cost for a package. In terms of benefits, we have a 12-point criteria that we normally use to determine what benefit to pay for, and it goes as far as how much will it cost to have that service, what is the severity of the disease, what percentage of the population is affected by this particular disease, and like the risk of out of pocket. And I'll give a good example, like for dialysis. You need around majority of them need 2 sessions in a month, in a week. That translates to around 8 sessions in a month. Yeah, we are paying at 9.5 per session, so that's 76,000 in 1 month. So this, if you leave to any Kenyan even to copay, then they won't be able. Most majority of Kenyans won't be able to sustain. So when you're looking at this particular package, then we have to finance it 100%, because the risk is very high, and this is someone who will depend mostly on dialysis throughout their life unless they undergo a kidney transplant. And that now brings me also to packages like the kidney transplant package now, where we also have to finance it 100% because of the risk of out-of-pocket payment. Yeah, so those are the things that go into designing a benefit package. Yeah.
You've spoken about something that I think might interest you. You've spoken about how many people, or compared to the population, how many people are of that particular type. Wouldn't that be letting others not to enjoy NHIF services, because they might already be offering or they are already members of NHIF, so they are contributing to the pool of resources. Don't you think that they might be at a disadvantage for them not getting services?
Now, when you're designing a benefit package, it's more of like an insurance thing. So you pull in funds together, and then when you're well and I'm sick, it will take care of me. And then when someone else is sick and I'm well, it will take care of the other person. So the model is based on sustainability also, because there's no need of covering everything, and then within a month or so you cannot be able to pay hospitals on time or something of the sort. So that is why we have to work out what is more severe, what is more detrimental, and it's based. You realize we have added benefits into our package because we realize there is need, so we have to stretch to see how much you can cover, as much as the government also supports us. So we're also undergoing new reforms right now to see how much more we can put in our benefit package in line with the new Kenya Kwanza manifesto. So once that is done, I'm sure we will be able to add more benefits to this big pool. Yeah.
Interesting. Yeah. And there is something that you mentioned, that funds will go to the facility even before a person goes there for services. What if the number of people who have subscribed to a particular facility, they do not reach that threshold of going to that particular facility? Are there claims that NHIF will do from the hospital so that it can reclaim some of the monies that have been deposited at the hospital, or how would that play out?
Now, for outpatients, there are various models that you can use. We have fee-for-service, we have fixed fee-for-service, we have capitation.
Yeah.
So when you have a very big pool of beneficiaries, it's always, for now, outpatient works best for us, because we have so many people, and it's based on how many people choose your facility.
Yes.
So if you're a popular facility and you have the capacity, you'll have so many people who have chosen you. But remember, the amount we are paying out is not like the one that matches the invoice. It's a little amount.
Yes.
Based on the fact that many people will choose you. So many people will choose you, yes, but not all of them will come for service.
True.
So that is what we base on. And it has helped, especially in the far-flung areas, because you find hospitals have even gone into preventive healthcare. So they prevent people from now coming to hospital. So they go into even community health. So they even go support, especially people with chronic illness. Some of them even send their staff there to just go there and do continuous monitoring to avoid them getting ill and then now coming into hospital.
Yeah.
So it more shifts the risk to the facility. So they do more on their side. Yeah.
As we're winding up, what message do you have for Kenyans to assure them that they will receive services and benefits when they go to a facility and they will be under universal health coverage?
Okay, now the government is very transparent. Yeah. And whatever the government says and whatever NHIF says they offer, they do offer. And there's so many benefits and so many beneficiaries who have benefited from these particular packages. And that is why we have gone ahead and expanded our scope. And I normally say healthcare is very detrimental. It is one of the highways to poverty. So you can be very rich today, but just one disease condition can take you to a poor life. So we normally advise to have an insurance. And the best insurance is NHIF because it offers so many benefits at a very little amount of money. And the good thing is, even those who cannot afford to pay, the government have considered them and are paying for them. Yeah, so it is a good place to start. And we have a very broad range of benefits that someone can benefit from. I mentioned the 7 broad benefits. So, yeah, come on board and we'll walk this journey together.
All right. Besides the questions that I've asked or the concerns that the viewers might have had, is there anything that you'd like, that I probably did not touch base on, that you'd like to inform the viewer?
Now, unless I just go into the benefits, one by one, maybe brush through. Like for patient, I'll mention those patients who have chronic illness. So initially, before we had a standard payment mechanism, and they used to suffer a lot. So since July, we adjusted the risk. So if you know you have a chronic illness, you have hypertension, you have diabetes, you have asthma, you have cancer, then we advise you to choose a level 4 or 5 hospital. Because the amount you're paying to them is higher. We have raised the amount for them to be able to take care of the chronic illness patients. So that is an important part that people miss. So when you have a chronic illness, now you're not supposed to be paying anything extra to facilities. Just choose a level 4 or 5 hospital. You'll be able to get all the services there.
So it is important for a beneficiary to first understand what, not to predict sort of sickness that you might find yourself in, but to sort of understand what health services might I need, so that you subscribe or you choose the profile facility that will be able to offer those services to you.
That's very true, because you know we have been having a challenge with chronic diseases. We have not been able to even build a proper database to know how many people suffer from diabetes in Kenya, how many people suffer from hypertension. We have the data for the communicable HIV, TB, and they're well supported, but we have missed data on this. And you know right now that they're becoming the highest killers very fast. So we are building that database, and that's why the reason why we advise, if you know you have a chronic illness, to choose a level 4 or 5 is because that's where you'll find consultants. So if you are undergoing hypertension or diabetes, you need to be visiting a physician at least once every month. You get your medication, you get some tests done. So that's why we advise for that. So if you know you're suffering from a chronic illness, then we advise you to go through that route.
Interesting there. And without anything else to say, I wish to thank you for coming for the interview, and thank you for the work that you all continue to do at NHIF to make sure that you keep Kenyans healthy.
We appreciate it.
All right, thank you very much, dear viewers, for being a part of this particular conversation. We've been talking about NHIF, UHC, and all the benefits that you'd get when you become a member of the National Health Insurance Fund. Mr. Otieno here has spoken to you about how exactly benefits are built so that you are able to access them. If you missed the entire conversation from the start, you can head onto our social media platforms at Science TV Kenya, at Science TV Kenya, that is on Facebook, that is on YouTube, across other platforms, and you'll be able to get snippets and full updates of this whole conversation. Now, Inclusion One-on-One is also still happening, and yesterday the National Council for Persons with Disabilities launched the first ever mainstreaming report, and you're going to be watching what exactly was happening there. And the chief guest for that particular event was the Cabinet Secretary for Labour and Social Protection, Madame Florence Bore, and amongst other guests at the event were nominated Senator Christo Asige and the Executive Director of the National Council for Persons with Disabilities.